to see, because you said, you know, you recognise the investment in CAMS. Well, it'd be interesting to see. I know CAMS is very one discrete aspect of the wider picture, but
absolutely,
you know, what impact these are having on waiting times, really.
Absolutely.
Okay, thank you.
Thanks, Darren.
Just wanted to ask about the detentions under Section 136 of the Mental Health Act. So we've seen evidence which suggests that obviously these are on the rise. Is there any particular reason that you think that they are on the rise? Is it because of a lack of inpatient beds elsewhere for children and young people, or is it more because we've got an increasing prevalence of mental health problems in society? I mean, what is your view?
Okay.
Yeah, I mean, I think overall the increase in Section 136 detentions for children and young people isn't necessarily associated with a lack of beds. Okay. I think you know, we've certainly seen a steady increase which is spread across the health boards in respect of 136 detentions. But I think in general terms, it appears that that increase is as a result of potentially a sort of increase in the pressures that young people feel that they're under, pressures with social media and so on, which has been quite well publicised. And it certainly appears to us that that's more likely to be the issue as opposed to a lack of beds.
So it's a rising tide problem, basically, in terms of
it appears that way.
Yeah. What I would say, though, is it's not a sort of spiralling problem. So you know, 48 for the year for my own force, for instance, in South Wales is still a relatively small number of detentions of young people. This year to date, I've just had a look this morning, and we've had 31 year to date. So it's seeming to be at sort of a figure around that sort of 40 mark for the year, as opposed to sort of an issue that's really spiralling. You know, the issue though for us would be that, you know, for any young person who's experiencing a crisis, anything we can do to work with partners to prevent the necessity to exercise police powers and deprive them of their liberty, you know, we should explore every possible avenue.
So, I mean, you've given me figures, obviously, for your police force area. So that would be typical in terms of, obviously, you've got to take into account population differences, but that would be typical as a proportion of the population compared to the other police force areas within Wales? Or is there a bigger problem elsewhere?
It's very consistent over the years. You know,
yeah.
We average around 20 detentions, and I think this year to date we've had 13. So, with, you know, 3 months left of the year, that would seem to be on course for a similar number this year. Yeah. But I also think there's been lots and lots of change in the past 12-18 months with Concordat agreements throughout the health board areas and the forces. Lots of training, the college APP, lots of triage interventions, and all that's now starting to filter through. So I'd be surprised if those numbers stay like that next year, and it wouldn't surprise me if we start to see a decrease next year. That's what I would.
So you're expecting them to come down?
I'd be surprised if they didn't come down with all the interventions.
Because obviously, you know, one of the concerns that's been flagged is that, you know, children and young people are being detained unnecessarily, that given the right support and advice and the right approach perhaps by the officers concerned, that it would make a detention unnecessary.
Yeah, and that's the benefit of the triage systems. You know, different forces do it in different ways, yeah. But certainly seeking advice is now mandatory under the Act, isn't it? Or trying to seek advice certainly for the officers on the ground is mandatory. So there's no option; they need to seek advice, and clearly, if you can get that advice from somebody professionally trained with mental health qualifications, with access to case notes, then you can perhaps point that person in the right direction, other than just the default position being detention under 136. And
just picking up on what you said before, Jonathan Drake, so the problem appears to be that the detentions under the Act, under Section 136, tend to be in those out-of-hours periods when you can't get hold of they're more likely to be in those out-of-hours periods and weekend periods when you can't get hold of a health professional, perhaps, to give the advice and guidance that an officer needs.
Yeah, and you know, the reality is that at 3 o'clock in the morning there are less other agencies around than there would, you know, and the police is a 24-hour service, so likely to be more involved at those times. But as I say, I think the issue with 136 is it's very easy to measure. My concerns would more be around the total involvement of police time in dealing with mental health issues of young people. So, as I say, within that day, there were 5 instances that we looked at. None resulted in a detention. So I think the 136, if you simply rely on those fairly low figures, it does somewhat underplay the amount of time and scale, really. Yeah.
Okay, thank you.
I think the key thing is the cops don't want to
detaining people, and it really is the last thing they want to do, because they don't want to be detaining children or did anybody who's in a mental health crisis. 136. It's just.
But likewise, if it's taking 4 hours of an officer's time, and I appreciate that's just a snapshot. If you've got to wait with someone in an A&E department, particularly over the Christmas period, it's more likely to be 12 hours in North Wales. On top of that, which takes your officers out of action for response purposes or whatever else they might be doing that day. Isn't there a risk or temptation that we'll just stick them in a cell for a few hours until they calm down?
No.
No, I don't.
You're confident that that's not an attitude?
No.
All right.
And we can't anymore. Lawfully, we can't do that anymore anyway. So it's no longer an option anyway.
Okay.
Okay, thank you, Mark.
Section 136, you have to take children to a health-based
place of safety. Yeah.
Safety. What sort of provision is there of these health-based places of safety? What are they across the?
Yes, absolutely. We can give you that. It's probably best if I come to you, Alistair.
Yeah, certainly. So, as far as the South Wales Police area is concerned, there are 6 health-based places of safety. Kevin Coyd in Swansea, Ward F in Neath and Port Ward 14 in Princess of Wales in Bridgend, Havant and Coyd in Llandoch Hospital in Cardiff, the Royal Glamorgan Hospital in Llantrisant, and Prince Charles in Merthyr. But we have taken children and young people to other health places of safety, St David's Hospital and in Cardiff, and Dyfed Ward in Morriston Hospital, because that is where there was a professional who was available in order to assess them at the time. So clearly we are in those circumstances trying to act in the best interests of the child.
And of those, how accessible are those, for instance, on a sort of 24-hour sort of basis? How many of those would be?
They are accessible on a 24-hour basis. But I think we've got to acknowledge the fact that outside of the sort of standard operating hours, then there is a significant reduction in available staff, which can then have an attendant impact on the amount of time that we're waiting.
So the mental health crisis Concordat says that these health-based places of safety need to be available for the police to bring young people to when needed. Their availability in terms of hours you've described, but are there circumstances in which the health-based provision won't accept children, for instance, if they're drunk or under the influence of drugs?
We haven't had any instances recently within the South Wales Police area where that's happened. There were a couple of instances last year where young people were diverted to A&E, and it was accepted that that was a mistake by staff at Havant and Coyd, and that's now been remedied. So from our perspective, certainly over more recent times, there haven't been any instances whereby young people have been refused at a place of safety.
As well, there's one health-based place of safety reception centre for detainees. It's the same unit for adults and for children, which is at Veriad Ward in St Caddocks. But again, similar experience through living memory. There's no, for me certainly there's no experience of a young person being turned away from that ward. And certainly we've been in a difficult position now, because if it was through intoxication or violence or whatever that would be, certainly a police cell is no longer an option anyway. So.
So the way the legislation works, and young person with mental health issues, where they've been sectioned under 136, you have to take to the health-based place of safety. If they're not in that scenario, but the officer perceives that there is a mental health issue, but also other issues, potentially their behaviour, what they've done justifying an arrest, can they in those circumstances be taken into custody? And if so, how do you then manage the mental health issues?
Yeah, they can. It would depend on the level of crisis, I guess, and what offence you're considering. So if the substantive offence is what the officer chooses to arrest for, then the young person would be taken to custody, and then the mental health issues then would be dealt with through the general custody provisions of forced medical examiners, where the CAMS would come into the custody unit to help assess a young person who's in custody. Again, that becomes difficult out of hours, but certainly the facility is theoretically there for that to happen.
Yeah. So even the hurdle level you need to section someone, if that was reached, if they had also committed, appeared to have committed a crime for which you wished to arrest them was sufficiently serious, then that would take priority, and you wouldn't therefore section them because that would be inconsistent with holding them within.
Well, I think it would depend on the dynamic circumstances of each incident, and you may be talking of a murder, for example. And the officer may decide that this person needs to be arrested for a murder, so that person would then be arrested, come into custody, see a nurse or a doctor, and an assessment would be made on the mental health of the person, whether they're fit to detain, whether they're fit to interview, whether they need a full mental health assessment and a section, and should they decide that needs to be the case, then the necessary medical intervention team would come in from, whether that be CAMS or the health board, and undertake that assessment. And then if that would then take precedence over the criminal justice side of it. So if the medical professionals say this person needs to be in a hospital because they're seriously unwell, they would go to a hospital because they're seriously unwell, and then we would pick up any criminal justice just aspects later on.
Even if they'd been arrested for an apparent murder.
If they're not safe to be held in a police station because they're unwell and because they're not fit to detain, and they're under a doctor's surgery in the section, and then we would need to then clearly the health of the child would take precedent.
But just to be clear, we in those circumstances would be going with them to the hospital. They're not released to the hospital on their own. They're still a PACE prisoner.
In the circumstances where, as you mentioned, I think just over an hour to just under 8 hours that a police officer was taking following a sectioning of a child, what are they doing during that period? I mean, if they're being taken to their health-based place of safety and that's working, can't the health-based place of safety take over at that point? Are the circumstances, say with a 7 hours 55, where the officer's needing to remain throughout that?
Yeah, I mean, it certainly is the case that more often than not the officers are required to stay at the health-based place of safety on the basis of safety of the staff, and it's only up until the point that health are prepared to accept the individual that the police officers can really leave. So we are there in order to safeguard the individual, but also to safeguard the health staff as well.
And if, as you say in your paper, that these health-based places of safety are the same for children as they would be for adults, are we therefore treating those under 18 in an environment suitable for their age, as is also required?
Well, as I understand it, I mean, the young person is taken to the crisis suite, which is a crisis suite for both children and young people as well as adults. I'm not under the impression that they're actually treated in the presence of adults there. So there is the facility to separate them from adults who might be in mental health crisis as well.
And for South Wales, this range of health-based places of safety, is that the right approach, or could there be an argument to say that the T Lydiard Centre, which the committee went to see, perhaps increasing the focus on that for assessing and then dealing with people?
Yeah, certainly as part of the crisis care concordat and the subgroups that meet as a result of that, it's certainly the consideration that the three health boards are of the view that maybe a regional facility, but when I say regional facility, I mean for the South Wales police area, which covers the three health boards, might be a workable solution from the point of view of being able to take children and young people to one particular place which could act as a centre of excellence. So we would see that potentially as a worthwhile solution.
And, another alternative under the Mental Health Act is the place of safety may include a local authority care home, an NHS or private hospital, an independent care home, or any other suitable place, the occupier of which is willing temporarily to receive the patient. In light of that, have you or partners considered alternative models of provision that might work satisfying that clause?
Considered, and I don't want to speak for health board colleagues, but I think a lot of it will come down to demand and where you put your resources, because the numbers we're talking about are fairly small. So whether you then invest in a unit for young people is a difficult decision, I guess, for those people who are holding the purse strings for the health board. And I guess at the moment, certainly in Gwent, the decision is that there's one reception centre for adults and for children. Not perhaps ideal, but it might be the best use of resource.
Yeah. Thank you. Finally, from me, I past life served on the Kent Police Authority and was a member of Parliament for a constituency in Kent, and I felt there was a lot of frustration from the police there that they were the people at last resort always having to deal with these mental health issues, and partners were not necessarily sort of pulling their weight in that process. And just looking at this concordat for the crisis mental health situations in Wales and listening to your evidence, my impression is it's working reasonably well in Wales. Would you concur with that summary?
I think there's still opportunities to reduce demand on policing and for young people who find themselves in a position of crisis for that to have been prevented at an earlier stage. So I think there's still opportunities for greater triage. I think that there's opportunities for us to use powers less because other interventions have taken place in the run-up to that. And I think it's fair to say that it's still seen as quite a challenging area of business within policing in Wales. What I would say, though, is that, you know, generally the relationships that we have with partners and the kind of being on the same page and working towards getting better is very, very strong here, and it does feel like a team effort.
Thank you.
Thank you. Julie.
You've mentioned triage quite a lot this morning, and obviously see it as a way ahead. Could you tell us how widely triage is used and what are the different models?
Certainly. So within South Wales at the moment, we don't have a triage at all. So we're developing an approach where we'd look at a community psychiatric nurse working extended hours within our control room and being available possibly 24/7 or slightly less. We've looked at that in the past. The issue is with funding at the moment. It's likely that we'll need to fund that as a police force. Obviously, we'll be capturing the benefits for all partners as a result of introducing that approach. Within Dyfed-Powys, they operate a triage car. In truth, a lot of that demand is also dealt with on the telephone. But it is seen as a really successful and positive thing to do. But so that's the approach they've taken. And in Gwent, it's a little bit different.
Yeah, and in Gwent, we've for the past 9 months, we've employed an approved mental health professional in our first point of contact centre on a trial basis. A fairly successful trial, so that officers, when they come into contact with people in mental health crisis, can contact the professional in the control room. Get access to first-hand, qualified advice. And that's proved really successful to the extent that we're now employing a team of 5 mental health professionals plus a supervisor to sit in our control room, not quite 24 hours a day, but certainly between the hours of 10 a.m. and 2 a.m. in the morning, to provide that advice to all our officers. And, you know, I suppose, unfortunately, like Mr. Drake says, that's been funded out of policing budgets as well. So it's almost like, you know, we're branching out into a new area of business, really.
Right. So when you say it's been successful, I mean, how do you judge the success?
Just in terms of crisis provision, I think, in terms of outcomes for patients, feedback is that the amount of detentions when the professionals working is massively reduced, which is why actually I expected a reduction across the board next year when that's fully in place. And just by access to information, you know, our officers are trained to the best of their ability. You know, we can train our officers for 1 or 2 days a year on mental health. But if they've got access on the telephone, and if the patient in crisis can speak to somebody on the telephone who's an approved mental health professional or the psychiatric nurse, then clearly that patient in crisis is going to get a better outcome. So that's for me where the success comes.
Right. And what about anywhere else in Wales? Do we?
I don't have the position for Northern
Oh, unfortunately, we've not
not aware. So
Right.
I can just talk about the three forces. Looking across the border, it's fair to say similarly there's a variety of models, you know, from telephone-based provision through to joint crew triage cars that go out. But I think that the main point is that there's people with access to really good quality information who are appropriately trained and can advise officers in real time and speak direct to patients. Obviously, we watched with interest the experience at Gwent, and that's helped shape the business case for our own model in South Wales.
Right. And how are you managing to fund that?
Well, at the moment, the plan would, because we're so committed that we need it, that we want it, that it's such a significant portion of demand, that our scenario would be that we'd need to fund £350,000 to make it happen. But we believe if we do that and we can prove the benefits for all partners, then we can revisit the funding question. You know, if I had a wish list, it would be for £1 million for Wales to fund a consistent provision in each of the 4 Welsh forces.
Do you think this is one of the key things for addressing the issues that we've been raising?
I do, and I think, you know, when you look at the multi-billion-pound budget around health and public service generally, to me it seems like a very small, you know, investment to potentially have a significant impact, particularly in terms of the well-being of patients.
Thank you.
Thank you. John.
Yes, I wanted to return to joint working between police and health professionals. We touched on the Concordat, which brings agencies together to look at the whole system approach. So it's from prevention and access through to recovery and ongoing well-being. Do you mentioned, I think, Jonathan, that there is room for improvement. You know, there is more that could be done. Would you like to see any particular action taken that, you know, would lead to those improvements that you mentioned earlier?
So I think the triage is the clear one. The other issue is in terms of, which is a positive, is in terms of governance. The Mental Health Concordat group was re-implemented. It stopped for a while after the Concordat was introduced. That's been reformed. I think that's a really positive Pan-Wales meeting and the ideal forum to take forward on a multi-agency basis all issues associated with mental health. So beyond triage, I can't think of a single sort of issue that I'd be pushing for. I really think that's the golden nugget for us.
Okay. And you'd agree with that?
Yeah, I think so. There is a will for change, certainly, you know, within the United Environment Health Board that my force sits in. There is a real commitment to a root and branch reform, I think, of mental health services, and there's a board for change which operates at the moment, and which, you know, I've been invited to sit on, and so I take up a seat for the police, and that cuts right across crisis provision, but also every other aspect of mental health provision, and that's been informed by service users as well as professionals. So there's just so much, you know. I know South Wales have already got things like the sanctuary provision and crisis housing. There's just so much, and it almost the redesign and the new operating model, which, you know, I think the health board will come up with. It will be a big step forward, but I suppose like any redesign of a big service, it's a slow process. So it's just that for me, it's just giving that our support and, you know, your support to what they're trying to achieve.
Okay. You'd agree with that?
Yes, I mean, I think from the point of view of looking back historically, information sharing has often been a hurdle. We've got the WASPI agreement that's in place now, and it's quite clear that things have improved significantly. Having said that, I think, as the ACC has mentioned, triage we see as being the way forward, because our proposal would be to have embedded, as we said, community psychiatric nurses within our police control room who would have access to the relevant records for the individuals that we're likely to be dealing with. So from the point of view of information sharing and overcoming that hurdle, we see triage as being a means by which we can do that. So it's certainly the case that things have improved considerably, but I think that extra step will really make a big difference.
Is attendance at strategy meetings an issue at all at the moment? Or?
It has been. I mean, I don't have any actual data that I can refer to, but certainly anecdotally it appears to be that attendance at strategy meetings at a local level in respect of difficulties that a young person's face has been sporadic, and likewise some attendance at Concordat meetings has also been sporadic. And so I think if there's an opportunity to improve that, and I don't know the reasons for that, it may just be literally a lack of resources to enable attendance, but I think that's another opportunity to improve things a little.
Okay, thanks for that. I wonder if I could move on quickly to funding. We've heard from some stakeholders giving evidence that they perceive a need for greater transparency and clarity around funding for key elements of crisis care, and particularly with a view to ensuring sustainability, so we could be confident that there will be sustainable funding for those key elements as we move forward. I just wonder, from a policing perspective, really, what you think in terms of use of Welsh Government funding. You know, is it being best used at the moment? And you know, what would a gold standard look like in terms of use of available funding and funding as a whole?
Okay, so certainly we recognise the extension of CAM's provision. I've overheard some discussion about whether that could be made 24/7 rather than extended hours. Obviously, that would be something that we'd very much support and would go towards that sort of gold star provision. Talked about CPNs in control room as well. You know, the more we can do around information sharing generally, I think, is a positive. You know, it's perhaps more general than to do with young people and mental health, but would benefit every aspect of multi-agency working is around multi-agency safeguarding hubs in each area. We don't have them in each area, and I think, again, at that sort of low level, long before people are in crisis, the ability to really share information on a multi-agency basis, so pushing those MASHs, multi-agency safeguarding hubs across Wales, I think would be really you know, a really positive development as well. I know that if colleagues from Dyfed Powys were here, I think they would raise challenges around rural provision as well, and in terms of sort of geography and travel times. You know, so whilst volume may be lower, you know, in terms of time, purely in terms of travel and the logistics of that. So, you know, an increase in rural provision, I think, would also be a push when we look on a pan-Wales basis.
Okay, and would Alistair or Nicholas like to add anything?
No, I think there's some service. The resources are difficult for everyone, aren't they? Making best use of your resources is the key to it. I think operationally, our staff need our support. It's having those, for me, it's having those clear pathways for our operational staff, so everyone's clear in the different agencies where responsibilities begin and end, because there's sometimes a blurring or a lack of clarity between our staff who are actually making these decisions at 3 o'clock in the morning as to whose responsibility something is, or whose responsibility the patient is, and where those lines are drawn. So if I was to ask for me, I suppose that it would be that clarity for our staff on the ground to make sure that everyone's trained, the police staff are trained in the medical procedures, but also vice versa, that the health staff are trained in the extent and the limits of police powers, because I think sometimes it is an unrealistic expectation of what our operational staff can do in the limits of their powers, and sometimes a frustration, I guess, on behalf of both sides, because they don't quite understand what each other is trying to achieve.
Thank you. Are there any other questions from members? No? Okay, well, can I thank you all for attending and for answering all our questions. It's been a really useful session. Thank you very much. And you will receive a transcript to check for accuracy in due course. Thank you. Okay, item 5 then is papers to note. Paper to note 1 is a letter from the Cabinet Secretary for Education regarding the investment in the ALN transformation programme. This has been copied to us and was sent to the Chair of Finance Committee. Paper to note 2 is a letter from the Cabinet Secretary for Education regarding the implementation of the ALN transformation programme. Are members happy to note those? Item 6 then, can I propose in accordance with Standing Order 17.42 that the committee resolves to meet in private for the remainder of the meeting? Are members content? Thank you. Okay.